Good morning, good afternoon, good evening, depending where you are. I'm Ana Lucia Jacome, Senior Project Leader and Human Rights Expert at UNITAR's Division for People and Social Inclusion. I remain at your disposal in case you want to explore possible synergies on aging and older persons learning initiatives. I encourage you, dear participants, to send your questions or comments to the speakers by using the Q&A Zoom tab. To better understand the topic of the second event of our series this year, access to health systems for older persons in conflict areas, let me explain why we have chosen this topic. Older persons in conflict areas face several challenges, such as the breakdown of health infrastructure, priority segregation, displacement, limited access to essential medical care, medication, and support services, exacerbating their vulnerabilities. In this regard, our learning objective is to better understand some specific barriers they face in receiving adequate healthcare and to advocate for age-inclusive humanitarian responses that ensure their health needs are met during and after conflicts. Without further ado, I have the honor to warmly welcome Mr. Chirian Matthews. He's Chief Executive of Help Age International that provides the Secretariat for a Global Network, which brings together over 200 member organizations around 100 countries with a shared goal to promote the well-being, dignity, and rights of older persons. Chirian has more than 35 years of international development experience in leading and managing humanitarian long-term development and advocacy work at country, regional, and global levels. In his long career, Chirian has engaged in wide range of research and policy issues like food justice, climate change, inequality, and humanitarian action. Currently, he is pursuing the policy agenda on population aging and promoting the rights of older persons, specifically looking at intersectionality with gender, disability, and climate change. He's one of the board of directors of International Federation on Aging and a board member of the International Civil Society Center. Please, Chirian, the floor is yours.
Thank you so much for that introduction and welcome to all of you for this particular webinar. I'm so excited to be part of this webinar and also I would like to really thank the co-panelists who are joining this webinar. So I have a slide deck, so I'll just take you through the slide deck for the next 7 minutes, if that's okay. So can you just see the slide deck now?
No yet.
Not
Should
yet.
be coming.
Okay, let me try again. Now?
No, no yet. Yes, now we can see it.
Okay. You can see the full screen as well, isn't it? Fantastic. Thank you so much. So as Anlucia said, my name is Chirian Matthews. I work with the HelpAge Global Network. It has around 200 member organization. And what I am going to share within the context of the topic would be the lived experiences of some of our local partners and the older people with whom we work. And I just want to start by saying that how important is this topic? You know, the older people in emergencies, the kind of scale of the issue, I just want to really articulate that. You know, as you all know, 1 in 5 people would be an older person by 2050. And within that, around 80% of the older people will be living in lower and middle income countries. That's the kind of a scenario that we are talking about. Older people are often overlooked in conflict, disaster, and displacement. Interestingly, in Ukraine, if you relook at it, according to 2022 work, 1 in 3 people were needing humanitarian assistance as a part of the conflict. And again, older people needs are frequently unaddressed, which I'll explain further on that. But one of the most important challenges that we face when we work with the older people is that a lack of disaggregated data, which inhibits investment as well as action around it. At the same time, I also want to really project another scenario where our research shows that in 2020, around 12.3% of the population living in fragile countries, especially those who are aged over 50. That will increase to almost 20% by 2050. But current the global warming as well as the current conflict that we have seen, this will increase significantly and substantially. That's something that you need to watch out. Coming back to some of the challenges that we face, I think some of it already as mentioned, but I just want to highlight most important one. Of course, quite often we have seen when we do the response work in the humanitarian response work in different contexts. So the older people are quite often living with one or more chronic non-communicable diseases. This is quite an important factor. And then, of course, the lower immunity, the increase in the risk of the communicable diseases. But I think the one of the fundamental thing what we need to really understand that there are limitations in mobility and senses and also the lack of mobility aids also aggravate the kind of an issue that we have. Of course, there are challenges around nutrition, challenges around lack of a limited capacity to access health services, but it all are boiled down to three fundamental challenges that we see, especially when we deal with older people. The first one, the isolation and living arrangements. Quite often, it is hard to reach. Sometimes people forget they are isolated. They are not accessible because of the way they live. The second is the ageist attitude. I think this is the most fundamental challenge. Ageist attitude among the older persons, sometimes also the health workers or the caregivers, even the community, because quite often they have been seen as they don't need much support, but they will take care of themselves. That kind of an attitude and ageist attitude. The last one, which I just want to really emphasize, the lack of participation or involvement of older people in designing the health support in the humanitarian context. They are invisible in that sense. And I just want to portray a couple of stories, one from Turkey, the other from the Ukraine. It's a heart-wrenching story where we see that we waited for days in the cold, and the younger ones went to the uh, uh, distribution points, whereas the older person could not walk and nobody asked what I needed. That's one of the expression of older person. Similarly, I felt forgotten and helpless, but when the helpage team came, they brought me everything I needed, medicine care and even a special mattress that helped me with my bed stores. This talks about the volumes of stories like this in different conflict and disaster context. We have done a survey and we have a report which is called Out of Sight, Out of Mind. And that report really shine a spotlight on the older people issues, the lack of participation, lack of involvement. But I just want to really spotlight on the women, some of the challenges that especially the older women face. And we have found that around 58% of those are living alone or they also care others. It is so fundamentally important to understand that some of the older people, some of the older women also caring either the children or the spouses or other persons who need care. Then they don't have any health access, around 56%, around 58% also access to food was challenging in the humanitarian context. Of course, the women normally live without much of an income. That also exacerbate those challenges in this context. And lastly, which we often found that the older women have many challenges to cope with the disasters and conflict than men, which we have seen. Then coming back to the kind of work what we do as a humanitarian organization, what we are trying to do is to really find, identify, and remove the barriers so that individuals and groups most at risk can be really reached out and their participation in decision making is ensured. And HelpAge is committed to ensuring all the people's rights in all humanitarian responses. But I think one of the things which we have quite often forget is that sometimes we feel that always older people need assistance and support, but older people can also act as a change agent in the crisis. For example, in Ukraine, despite the challenges they face, they have a vital role of caregivers, community leaders, and advocates, and they can do that. In Syria, based on our research, almost 63% were caring for at least one child, being an older person. And so, as I said, the older person continue to care for other older person as well. So they are playing a vital role. And in Ukraine, we have a model where older social care workers providing that support to the older people. And we need to really make sure that an inclusive system of response where older people are also really playing a role when it comes to the humanitarian response. Now, in terms of some of my recommendations, these are something that I just want to address. How do we move from a neglect to inclusion? What must change? The first and foremost, the improved systematic allocation of sex, age, disability disaggregated data. I talked about that. Data is key. We need to work around that. And the healthcare services must be designed to be accessible and responsive to the specific needs of the older people. This is fundamental. And older people must be included in emergency health response plan. How we make sure that their participation is there to really make sure, and ensure the efficiency of reaching out to the older people. Then we need to have different models of work when it comes to the humanitarian setting and armed conflict to have better access for older people. Community health teams, community-based care services should be established to deliver essential health care to those who may be unable to access traditional healthcare system. And then integrating palliative care for older adults with chronic condition or end-age diseases is essential to manage pain, reducing suffering, and improve quality. Finally, healthcare professionals must be equipped with necessary skills and resources to provide compassionate, competent care to older people. So that's all I just wanted to submit. It is so important to consider that, first of all, older people are not just not just a recipient of benefits, but they can also be actors, and they can really play a role in really creating more access to older people in crisis for the health system. Thank you so much.
Thank you. And congratulations for all the initiatives you have been leading and you have been focused throughout these years. Thanks also for stressing on the strengths of older persons instead of just focusing on their needs. As you said, data is quite important to measure the development of action in this important topic. Now, let me warmly welcome Madame Sue-Ann Bell. She's an associate professor at the University of Michigan School of Nursing in the US. Her research focuses on the health and well-being of aging populations in the context of disasters and public health emergencies. She's serving as a 2024-2025 National Institutes of Health visiting scholar, as well as on the US Department of Health and Human Services National Advisory Council on Seniors and Disasters. She's clinically active in disaster response as a nurse practitioner with the National Disaster Medical System with over a dozen recent deployments. Please, Madame Sue-Ann Bell, the floor is yours.
Thank you for having me today. The main message that I want to convey today is that climate change and conflict intersect to disproportionately impact older adults' health and safety worldwide. And greater attention is needed to create policies that empower, support, and center older adults in conflict and crisis settings so that they can live their fullest lives. So I have no disclosures, and my research is supported by the National Institutes of Health. Just to introduce myself, in my day-to-day life, I'm a professor of nursing at the University of Michigan in the United States. And I conduct research on aging, disasters, and health, including how to promote healthy aging and how to build more resilient healthcare systems. But as was said in my introduction, I'm also a nurse practitioner by training. I'm a member of a disaster medical assistance team, where in this role, I deploy to disasters in the US that exceed local capacity, providing basic and advanced healthcare, setting up and running field hospitals, and providing health and healthcare education to displaced individuals. So as a researcher and as a clinician, I always say that my research informs my practice and my practice informs my research. So as this map illustrates, crises across the globe are widespread and intensifying, with conflict and climate-related disasters driving displacement on nearly every continent, displacing millions, including many older adults. And in many of these regions, healthcare systems are overwhelmed or inaccessible, compounding the risks for populations with chronic health conditions or disabilities. And despite these known needs, older adults are frequently overlooked in global humanitarian efforts, leaving behind critical gaps in protection, healthcare, and psychosocial support. So I wanted to talk for a minute about climate change impacts. The CDC Climate Change and Health Wheel shown here, it helps to visualize how climate impacts like extreme heat, air pollution, and extreme weather affect health outcomes across populations. In conflict and crisis, these risks are magnified, especially for older adults who already may have pre-existing health conditions. This wheel reminds us that climate-related exposures don't just occur in isolation. They cascade through systems like housing, healthcare access, and emergency response capacity, all of which are often disrupted during times of crisis. This slide. So aging, as we've already heard, comes along with certain changes for some, but not all, that can amplify vulnerability in crisis settings. Frailty and mobility challenges can limit an older adult's ability to evacuate. Cognitive impairment can affect situational awareness, including understanding emergency instructions or how to access healthcare during a crisis. Economic insecurity may mean that they cannot afford to relocate, rebuild, or access needed medications. And social isolation, so common among older adults, can result in being overlooked during evacuations or relief efforts. In the context of conflict and climate change, these overlapping risks make older adults more susceptible to injury, illness, and even death, yet they're often excluded from emergency response planning and resource allocation. However, today's older adults are challenging stereotypes and reshaping what it means to age, showing us that older life stages can be dynamic, fulfilling, and influential. Studies show that older adults tend to have greater emotional regulation, for example, also empathy and the ability to find meaning in difficult times. So with age comes the chance to reflect on one's life and contribute to something lasting through relationships, creative work, community impact, or mentorship. This sense of legacy and continuity is deeply meaningful. And these strengths mean that older adults can use these lived experience to guide others in planning for emergencies. But I mentioned non-communicable diseases on the slide above, and I wanted to talk about that for a moment, as NCDs are a critical area for attention during crises. Non-communicable diseases killed at least 43 million people in 2021 alone, and of all NCD deaths, 73% are in low and middle income countries, where most crises are taking place now. But whether it's heat waves or conflict, older adults need tailored health protection. In fact, during most disasters I've responded to, it's chronic condition care that people seek the most, the need for regular and sustained healthcare to continue to meet their healthcare needs. And I rarely take care of people with injury and trauma after a disaster. The care I give is for high blood sugar due to diabetes, high blood pressure stabilization, and to address respiratory conditions. Access to healthcare is so important, but it's also one part of a larger system. Healthy nutrition is another. As an example, I show a picture here of a shelf-stable meal that was used in shelters after Hurricane Maria. If you're from North America, you might recognize these as classic junk food, candy, canned meat, and a bread-based snack, all high in fat, salt, and sugar. The alarming rise of NCDs tells us that this type of care is essential to include in emergency planning. So I am only going to bore you with one research study, I promise. Our research team studied long-term survival from certain types of cancer among people who experienced a major crisis. In this case, Hurricane Katrina, which was one of the worst catastrophes in US history. We compared this group to a group with similar characteristics and types of cancer, but who did not experience living through a disaster. And what we found was that the living through a disaster was associated with a higher risk for mortality, meaning people who lived through this crisis died sooner than those with similar types of cancer, but who did not experience a major disaster. The important takeaway finding here is not the hurricane itself, but instead the lack of access to regular and sustained cancer care. and the interruptions to daily life caused by the disaster that were contributing factors to mortality. So I hope this study might sit with you a bit because it's an important one. We need to ensure access to healthcare and healthy living for people with chronic health conditions, especially during crisis situations. So I want to end with a call to action. And here I hope that you can see on the right of the screen are larger ideas and ideals that we can put into action, while on the right are actionable and concrete steps that governments and organizations can take now. Aging policies must include planning to build climate resilience and preparedness, and those plans must be with, not just for, older adults. Older adults hold crucial community memory and adaptive knowledge. Their lived experience strengthens our response, and we need that input for planning. Thank you so much for having me. And I wanted to give a special shout out to my own parents who are showing me a model of aging with grace, dignity, and joy. I've included my contact information in the QR code here. Please do contact me to continue the conversation. Thank you so much.
Thank you so much, Sue Ann Bell. It's a wonderful way to finish your presentation. Thank you. Thanks for sharing all the good work you have been doing. We truly hope that you keep going with this endeavor that is most needed now. To continue, it's a pleasure to introduce Mr. Santiago Fiorio Baisken, member of the UN Committee on Economic, Social, and Cultural Rights. Among his efforts within the committee, he promotes national mechanisms for reporting, implementation, and follow-up of human rights recommendations, and he's also a member of the drafting group of a general comment on economic, social, and cultural rights in the context of armed conflict. He's also program coordinator for business and human rights and labor standards at the UN Global Compact office in Paraguay. Please, Santiago, the floor is yours.
Thank you very much. I'm very happy to be here with you. I'm honored to share some of the work that we are doing at this moment, particularly at the UN Committee on Economic, Social, and Cultural Rights. But before I engage directly into the latest developments, I would like to share with you some of the challenges that we are actually facing, and we have found in reports delivered by civil society organizations, UN agencies, and even from national reports regarding the issue of the lack of access to health services of older persons. So some of the challenges that we have that we have found are actually linked to factors of vulnerability in the conflict context. For example, health and physical vulnerability. There is a higher prevalence of chronic diseases, diabetes, hypertension, arthritis, which are reported to the committee as one of the main challenges that older persons face, but these are not duly faced by the health systems because of several challenges that are proper of armed conflict. Actually, there's an increased need for long-term care, medication, and regular medical follow-up, which is not met, needs that are not met, and there are difficulties in reaching health facilities. For example, we have found this in some regions. For example, in the latest situation of armed conflict in the western side of the Congo, in besieged areas, many persons die because of lack of access to insulin or dialysis, or even access to food. So these are some ongoing developments that we are now facing in the committee during the analysis of specific reports. But also there are other challenges, as the difficulties for mobility and the problem of displacements. Older persons normally remain behind in danger zones due to mobility limitations or even emotional attachment to their homes. So this is another challenge which is very difficult to face, because this is a situation when sometimes the states lose control over their own territory. I'm going to talk about the issue of effective control. Also, displacement shelters and camps are rarely designed with other persons' accessibility in mind. This is also something that has been reported by specific UN country teams, where we have found that, well, some UN installations, as a source of, as a in a form of self-assessment, they do recognize that sometimes even in the camps, these are not 100% accessible for other persons. Also, the issue of mental health and isolation, trauma, trauma from exposure to violence, the loss of family, and the displacement. This trauma is also very relevant, not only for the suffering and the mental health is compromised during the conflict, but this is also a damage that can last even post-conflict. So this is going to be a part of the state obligations that I'm going to refer to after, so in a post-conflict situation. So there are obligations during conflict and post-conflict situations. Older adults are also found excluded from mental health programs, which are normally youth focused. Even we have found this during our dialogue with Palestine, as the elderly people that reported isolation, depression, and lack of psychological support amid the destruction of basic services. We clearly understand that the Palestinian state, for example, they have control over the air over their own territory, but only in a partial way. There are also other obligations for occupying powers in this regard, and I'm going also to make some other reference just in a minute. Discrimination and institutional neglect. This is the fourth example of situation of vulnerability I wanted to bring today. Exclusion from data collection leads to the invisibility in humanitarian planning, and sometimes emergency response often prioritize children and younger adults, and unhappily, older persons may not be fully considered in these operations. An example that we have seen this was in the dialogue that we have last year with Yemen, where civil society organizations reported that older people were being deprioritized from evacuation and humanitarian service assistance despite their high health risks. So these are four, but there are other factors of vulnerability in armed conflicts because of 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 time constraints. I'm going to move forward specifically to the rights of older persons under the International Covenant of Economic, Social, and Cultural Rights. As you are aware, the right to health is considered under Article 12 of the ICESCR, where all persons have the right to the highest attainable standard of physical and mental health. So we understand that there may be limitations, particularly in context of developments, but it also applies in the context of armed conflict. There's also general comment. Our general comment, as you know, are documents that we draft within the committee in order to give an interpretation to the extension of international human rights standards and the interpretation of the rights which are enshrined in the covenant. So states must give special attention to the populations which are in vulnerability and marginalized groups, explicitly including older persons, even in emergencies. Health rights cannot be suspended in any way. And if there's arbitrary suspension of health services, these are recommend. This means that the states have a specific responsibility. So during armed conflict, we know that we can have national armed conflict and international armed conflict. So states retain their human rights obligations under CESCR even during armed conflict. So under international law, including the four Geneva Conventions, state must ensure medical services to the population respect and protect medical personnel and facilities, and facilitate humanitarian aid. These rights, which are enshrined in the Geneva Conventions, match perfectly with the interpretation that the committee gives to Article 12 of our covenant. There is also a responsibility from occupying powers. And here is where I would like to make a specific reference to extraterritorial obligations, which is something that is not visibilized enough according to our view. Extraterritorial obligations of the state parties to the covenant extend beyond their national borders, encompassing responsibilities when they exercise effective control over foreign territories or are involved in armed conflicts, such as occupying in the capacity of occupying powers. So we have identified extraterritorial obligations not only in the covenant but also in several general comments, particularly in the general comment number 24. And we understand that the extraterritorial obligations actually actually are the same of for all of the rights which are in the covenant. For example, if there is an occupying power in a specific in a specific territory, so that's the occupying power which has the responsibility of ensuring that human rights are protected right away. And these obligations are particularly not only all of the articles, including access to health, but also the obligation to refrain from causing harm. This is very important because normally in situations of armed conflict where there is an occupying power, we can see a behavior in which the occupied powers may limit or even suspend services, and this is a violation to the right to health. And considering the factors of vulnerability that older persons face during armed conflict, this is even a worse scenario. There's also a responsibility to conduct the due diligence of protection particularly in the right to health. So we understand that normally there are situations where a state may not be in full control of their own territory. So, for example, in our case, in the committee, we have established a practice. In the case of Yemen, for example, we understand that we can give recommendations to the state and make an assessment on the situations in which the state actually has control in their own territory during armed conflict. But in the case of if there's an occupying power, that's where we have to refer to the responsibilities of those powers also are applying for well the rights enshrined in the covenant are also applying for that is also applying for the occupied power as well. So just to go to the final section of my intervention, I just wanted to also not only focus on the situations of conflict. During conflicts, we can find these extraterritorial obligations. We can find everything that I said before, but there's also responsibility in post-conflict situation, which is something we should be also focused maybe in another event, because it is a very long this could be a very long analysis, but it is important that the recovery process also includes a population situation of vulnerability, and the post-conflict situations normally extend for longer than most of the armed conflict that we are facing at this moment. So happily, the Committee on Economic, Social, and Cultural Rights at this moment is drafting a general comment to bring a formal interpretation of everything that I have shared today. This is a part of the discussions that we're having at this moment in the committee, and we hope to bring and deliver results very soon. Thank you very much for the invitation and the opportunity to share the work that we are doing at this moment at the committee. And I'm open for any other comments or questions afterwards. Thank you very much.
Thank you so much, Santiago, for referring to post-conflict effects. While during an armed conflict period, surviving is a priority, of course. After that, taking good care of mental health faced to intrusive reactions or post-traumatic stress is a must. So thank you so much, and we wish you all the best in your wonderful endeavors. To continue, I have the pleasure to warmly welcome our dear colleague, Dr. Sara Ghanem, Health and Development Coordinator at UNITAR. She's a medical doctor from Egypt with a bachelor's in medicine and surgery from the Faculty of Medicine, Alexandria University. She's a public health specialist with Masters of Science in Public Health from the Institute of Tropical Medicine in Antwerp, Belgium. She has several years of experience working with she had several years of experience working with Médecins Sans Frontières in the field. Her work mainly focused on providing healthcare to refugees and migrants populations in the most challenging contexts who survived brutal incidences such as gender-based sexual violence and torture. Please, Sara, the floor is yours.
Thank you so much, Ana Lucia. It's such a pleasure to be here. Thank you for the invitation. And thank you for all the attendees. I will share my slides with you. So, yeah. So today I will share some of the insights I have from working in the field with the MSF. So as Ana Lucia mentioned, I'm a medical doctor by training. I did my master's in public health in the Institute of Tropical Medicine in Antwerp with a focus on health systems and disease control. So throughout my years with MSF, I worked in the field with refugees and migrants who are fleeing conflict areas with a scope focusing on survivors of sexual violence and torture. So I want to highlight the barriers that are faced specifically by older persons in such vulnerable context. And here I want to make this categorization into health systems related barriers and older persons related barriers and also barriers in transit. So in terms of health systems side barriers, first of all, there is older persons face like physical access barrier and mobility because in such setups, health systems usually don't have the capacity and the infrastructure that is planned and designed for older persons access. Usually there's no wheelchair access and there is a lack of facilitation of the mobility of older persons. Also in this setup, we see a lot of language barrier and the health workers or the health staff most of the time don't speak the local language of the population, and this can be a small thing that can lead to a huge communication problem. Also, the health systems face like it's stretched very thin in such context, and there might be insufficient medical staff, but also there is usually a lack of proactive awareness raising about the services that are being available, because there's usually a lack of community outreach and reaching remote areas where older persons can usually be isolated, and it's very challenging to reach these areas, especially in a conflict situation. There can also be insufficient medical supplies for chronic diseases, especially if you are like we realize that in conflict zones or in conflict areas, there are many actors on the ground, and some actors might have specific scopes that does not allow them to provide assistance in other scopes, which lead to discontinuity of healthcare, because you might have a person who was, for example, a survivor of sexual violence incidents, but at the same time, you don't have the medical supplies for chronic diseases, but he might present as well with hypertension and diabetes and other chronic diseases that need to be addressed simultaneously. So this shows a lack of comprehensive care approach and lack of continuity of care, and sheds the light on the weak referral systems that are usually in place between the actors in armed or in conflict areas. Second, the older person side barriers, usually, as mentioned also before by the panelists, that older persons lose their family and support systems along the way. They might not be fully aware of the severity of their condition, and they might also not be fully aware of the services that they can access and that are provided. And we can see that there is also a behavior of delay in seeking medical services in older persons, because they tend to prioritize others and not themselves. And this also leads to them arriving at the healthcare facilities in very late stages of their illnesses, as well as the language barrier that I talked about before. Also, along the way, they lose their medical records, they lose their medical history, and they lose their medications that might be chronic medications like for diabetes or hypertension, and they need to refill them, but not being aware of their conditions can lead to elongated and more timely consuming procedures until you can provide the right treatment, and also the mental health challenges and the mental health stress that they are faced with. When it comes to barriers in transit, usually the healthcare facilities are distant in some contexts, which makes it more difficult for them for older persons to reach, and the terrain might not be appropriate for travel and lack of transportation. Also, they are still they face some stigmatization and discrimination, especially with certain chronic diseases that can be non-communicable chronic diseases, but also communicable diseases such as HIV, who are faced with a huge deal of discrimination, and then isolation and lack of means of communication. In such contexts, you can be isolated and communications can cut, and then makes it even harder to reach healthcare systems. Now, I have two case studies that I want to share with you from the field that highlights how complex the situation can be, and all the factors that come in play. I want to mention that there were no real personal data used in these case studies, and it's just the stories from real life to highlight how it is on the ground. So here was a case of a 75-year-old South Sudanese female who speaks only the local language of Dinka. And then the clinic didn't have interpreters who spoke her own language. She arrived in a disoriented mental state and difficulty in recognizing place and time. And there were no available wheelchairs at the time. So she arrived with a stranger who was literally carrying her into the clinic. She didn't have any medical records or any medications on her. The vitals were unstable. The random blood sugar was very, very dangerously high. And thankfully, insulin was available for emergencies, but there needs to be a referral to a tertiary hospital for stabilization and further investigation. This was extremely difficult because of the language barrier, because of the lack of infrastructure and referral systems in place, making it very time consuming for her to receive the appropriate care that she deserves and that she needed. And moreover, the local health system was completely stretched that there were no beds available in the tertiary care hospitals. So we had to find another tertiary care hospital that was close, and she finally arrives there. But you can imagine the complexity of the situation and the timely consuming procedures it takes for this. And the second case is a different problem, and it's a case of a person living with HIV, but also a cardiac patient who flew his home country to the host country and also without his medication. But he presented with a totally different situation, with low back pain and weakened lower limbs and numbness. And then after the necessary examination and investigation, he needed a lower back lumbar disc herniation surgery. And be it a person living with HIV, unfortunately, in this setup, made it very, very difficult to provide surgery for them, because in the referral system, the local system had discrimination and stigma against people living with HIV, even from healthcare workers and the health system. So this took months, and also access to his medication, to his HIV medication and cardiac medication, was severely difficult. So he was, which took several months, and he was on conservative medications until then. And unfortunately, I had to finish my mission before this person had his surgery. So you can see how difficult it can be. And from here, I want to say that we need to integrate older persons in the initial design phase of humanitarian planning and in all stages that follow. And also, we need to apply a multi-stakeholder approach to this, with solid communication channels and referral systems between actors in the field. We need to establish solid systems to make this easier for everyone, and for older persons in particular, providing mobile clinics and community-based outreach in a timely manner in conflict areas, and also ensure the access to medicines of chronic diseases in all locations for continuity of care. Eventually work on dismantling the stigma and discrimination practiced by health systems and by communities in different areas of the world. That's it from my side, and thank you for listening, and I would be happy to answer any questions at the end.
Thank you, Sarah, for sharing your insights from your experience in the field, where language barriers, lack of infrastructure, not having access to a specific medication represent an additional challenge to ageism. Thank you so much. And to continue, it's a pleasure to give the floor to Dr. Michael Ashley Stein. He's co-founder and executive director of the Harvard Law School Project on Disability and visiting professor at Harvard Law School since 2005. He's considered one of the world's leading experts on disability law and policy. He participated in the drafting of the UN Convention on the Rights of Persons with Disabilities. He has wide experience working with different stakeholders around the world, including on disability laws and policies, and advice to several UN bodies and national human rights institutions, of course, including on aging issues. He has brought landmark disability rights litigation globally. Professor Stein has received numerous awards in recognition of his transformative work. And for UNITAR, he's a really good friend. He has been quite supportive throughout this process of the series. And welcome back to your online home, dear Michael. Please, the floor is yours.
Thank you so much for having me, and thank you for allowing our organization, the Law School Project on Disability, to co-sponsor and be in solidarity with UNITAR on this and many other issues. Just a few thoughts. This is not a formal presentation, which is my background comes from disability human rights. And of course, there is a significant overlap regarding the populations of older persons and people with disabilities. Myself, I'm now with one foot in both camps. So we ought to be learning lessons from what we've done in the disability field, but also learning lessons to avoid and how to improve as we move forward with programming and thinking. So specifically, I was very privileged to have worked closely with Ambassador Luis Gallegos on the drafting of the Convention on the Rights of Persons with Disabilities. We're enormously proud of it. We're approaching soon the 20th anniversary of its adoption. But today's webinar really highlights how we need, as we move forward with the treaty at the HRC, to really spell out all the different implications of the impacts upon older communities. From the disability perspective, we managed to have in Article 11 on situations of risk. And it's a very short article. It's only 3 lines long. We're very proud of it, and more so, we're proud of what has come out of it. There is no specific mention of conflict and post-conflict, but through some advocacy with the Security Council, Resolution 2475 does extend to conflict, post-conflict. I was privileged there to have made an intervention, but spelling that out is very important. Climate change is never mentioned in that article. And so it's very important that we spell out climate change as well. Refugees and asylum seekers are, again, not spelled out in that article. And in the current world that we are engaged with, mobility is forced both through climate disasters, conflict, needs, and so on, but is not specifically adopted within the article. So something that we really do need to emphasize when thinking about how to ensure that the full spectrum of rights for persons who are elders, including us, are included. A few comments on what some of my colleagues have mentioned. There is, of course, the issue of abandonment of older persons, but there is also, as mentioned, the idea that some will choose to stay behind, either through personal choice or through lack of options, or through simple preferences. And the connection of older persons, it's complex, just like any other population. Some are autonomous and individual and lonely and isolated, and some are tasked with being caregivers. And in the economic world in which we live, and with sandwich generations, very frequently the children are staying with the grandparents, while the middle generation is trying to work at subsistence or other levels. So what do we know about that as far as conflict and others? We should highlight things like the loss of, in cases of conflict, natural disaster, and others, the loss of assistive technology, the loss of caregivers and supporters, the loss of physical medicine, but also the loss of medical records and other documents. Most people do not walk around with all their documents or their birth certificate and so on. And when moved either as IDPs or as refugees to other places, they have an enormous difficulty in overcoming administrative barriers and procedures to accessing basic human rights and basic services. One day, probably, I don't know when, will all those of us who are fortunate enough will have a chip with all our information on it, either physically or embedded under our skin. But that's not the situation now. And so when you're put into a new place and you need to know what medicines you have, what your history is, allow medical personnel to do, to be able to profile you appropriately, that's a great challenge. We've spoken about the stigma on older persons, and I just want to really highlight that as well, because again, it's about not valuing those who are considered not as economically viable as others, and that extends to many different communities. And the people on the ground will often engage in triage. Human nature is going to be more empathetic to children who have not yet had the opportunity to have lives than to older persons. Human nature is going to be more inclined to help those without complexities, as many people with disabilities have, than those who appear not to have those complexities. And anytime we're talking about limited resources, we are automatically shifted, whether it's public health or otherwise, to a utilitarian idea of helping the largest number that we can in the best way possible. And that does not take adequate account of those who need accommodations, incorporation, and support. As far as older persons and responses, there is certainly a lack of co-design, and that is true for many other marginalized populations. Older persons are not being consulted and sharing their knowledge on what it is that they need in order to survive and to thrive. I am unaware of toolkits, for example, created with populations of older persons, in which here's what you need to know, here's what we know, here's what we can do together. The intersection of climate, disaster, and conflict is one that several panelists have pointed out. And again, it's very overwhelming and extensive. Several panelists have pointed out correctly that there is greater emphasis on physical and other sorts of effects rather than on psychological, less visibly discernible effects. And we have lots of data on that and lots of anecdotal evidence about it. So guidance for what operationalization should occur on the ground is absolutely necessary. The individuals who engage in humanitarian aid, who engage in human rights and resettlement are truly heroic and truly overwhelmed and truly working enormous hours. But if they're not given the guidance, they're going to do the best that they can. But again, the defaults are for the less complex, the lower hanging fruit. And again, the stigma about who we value and who we don't, it's not a coincidence that here in the US during COVID, at least 20% of the deaths occurred to older persons in nursing facilities. And that's probably a dramatic underestimate, because many of them were simply logged on their death certificates or data as passing with old age or natural causes. The same is true for the large cremation pits that occurred in India and other places. We hope to make a small contribution at HPOD. We've partnered with the Zero Project and their call for papers and for best practices and policies, which is open till the 22nd, encourages local responses, population responses to climate, to disasters, and to other relief. Hopefully they're creating of a platform, and I'll help them as I can. We'll be able to share local knowledge because every group knows its own needs and knows its own creative responses better than the external groups. Finally, I just want to emphasize that we haven't really spoken very much about abuse and exploitation that occurs as a result of forced relocation, forced movement, different situations by conflict, climate, etc. People are put into desperate circumstances. And however much they may be autonomous and powerful and psychically, great advocates, these circumstances are desperate. And we know across all communities, but especially across vulnerable populations, that abuse and exploitation occurs when people are put into situations where they need things on a desperate basis. So thank you ever so much for allowing me to share some thoughts. And it's a joy and an honor to be with you.
Thank you so much, dear Michael, for your insights. As usual, it's really good to have you here with us. We have some questions. The first question that is addressed to all the participants is the following. How can a future UN Convention on the Rights of Older Persons ensure access to health systems in conflict areas, building on the existing international human rights instruments? We will be starting the other way. So please, Michael, you have the floor.
Without avoiding the question, I would first of all endorse Professor Santiago's and the CERC's committee's idea of extraterritoriality. With conflict and post-conflict, it's enormously unfair that the aggressor can come and wreak havoc, and then it's the country against whom the aggression was posed is now responsible for taking care of their citizens. Of course, they are responsible for it, but there needs to be some kind of balance where the aggressor is made to do that. Beyond that, I very much like the approach that we had in the CRPD of having equal access to health, understanding that it's not a right to health, that it's not a right to all services, but a right to equal amount of services and access, understanding that there are times and places where resources are extremely limited. And again, I think we also have to put in a measure that talks about the value of life, and I don't mean that other than a standard right to life, right to quality of life, an equal valuing of all lives, as opposed to what is sometimes done, and it was done here, and some of us, brought lawsuits to oppose it, where crisis standards of care created a hierarchy of who should get services first and who is more valuable than others. Some of those, by the way, mapped out very badly on comorbidities with race and age, and I'm speaking from a disability perspective. So we need to value the equality and the access to care.
Thank you very much. Now, Sarah, please, the floor is yours.
Yeah. So I think, can you repeat the question, Anuncia? I'm sorry.
Yes. How can a future UN Convention on the Rights of Older Persons ensure access to health systems in conflict areas, building on the existing international human rights instruments?
Yeah, it's a very interesting question. I think from my point of view, also I like to keep it a little bit in touch with what's happening on the ground, and I think there needs to be more linkage and more translation of the UN conventions to the local workers and to the people who are working on the ground. I think in terms of conventions and in terms of very sophisticated written documents. It's really great to see that now there are more issues that are spotlighted, and we have more issues that are coming to the light when it comes to this. But I think it's also important to find the mechanisms, the right mechanisms to translate this into action, to facilitate the process from these documents into what will happen on the ground. And I think there also need to be a lot of accountability and also put mechanisms that ensure accountability of the actors and all the different stakeholders involved in the humanitarian responses to uphold these rights and conventions, because usually it's important to yeah, to find these mechanisms in place to hold people accountable rather than reinventing the wheel or going for more conventions and such things. Thank you.
Thank you, Sarah. Please, Santiago, the floor is yours.
Thank you very much. I am very interested in extending a little bit more on the concepts of responsibilities that I have mentioned, which are actually apply to this discussion, particularly with those responsibilities that Dr. Michael also referred to in his previous comment. The extraterritoriality of obligations are applicable in the context um, um, of international armed conflicts, but at this point, it has not been thoroughly considered by the international community, and this is something that we need to work from our committee and also from other treaty bodies as well, because although we have conventions which are specific for many specific groups, um, the interpretation of international human rights law must be interpreted in an extensive way, in complementary to other applicable treaties. For example, if we have the conventions on the right to of the right for people's with disability, or the conventions of the rights of a child, or other conventions, and there is no international convention of the rights of elder persons, which is a huge gap from my perspective, international community. We need to make a complementary interpretation here. But something which is very interesting is that at least in the American region from which I come from, there is a regional convention of the rights of elder persons. There's an Inter-American Commission for this, and normally when we engage into the assessments of human rights situation in specific countries which come from the GRULAC region, we can use also those resources in a complementary way. So my by giving this example, I just wanted to bring out that extraterritoriality is also applicable for the interpretation of other international human rights law instruments, for all of the human rights conventions, and from the universal point of view. So I just wanted to bring this here, and something that I have omitted. I have been taking looking at my notes here. I have omitted something which is very important. So which are the main responsibilities of occupying powers in terms of extraterritoriality, and these are mainly grouped in three main points, which is the respect of fundamental rights, not only what is within the framework of the CESCR, but also other human rights instruments which are applicable in this area. And what I mean applicable is that we also have to consider the regional instruments for international human rights law. Then there's a protection of civilian infrastructure. This clearly includes hospitals, schools, and water supply networks, and other infrastructure, which is be very useful for, which is not useful, which is essential for the protection of the rights of access to equal access to health, and obligation to provide basic services. So these two are complementary. So this is something that we have seen as a behavior which has not been complied with in many contexts, even in the case of international or national armed conflict. So this is important to take into account, because the applicable law could be different in order to at some point provide not only a specific a specific judgment, but also the adequate legal remedies for human rights violations in this regard. Sorry, I diverted a little bit from the from the previous comments and questions, but I just wanted to bring this because this is something I consider very important, but I involuntarily omitted in my presentation. Thank you very much.
Thank you so much, Santiago, for your insights. Please, Madame Sue Ann Bell, you have the floor.
Thanks. I'm going to keep it pretty short and sweet. I think one overarching theme from this conversation today was about promoting health for older adults, and along with that, using lived experience to promote health and better quality of life during climate-related disasters or during conflict. So I would say that when we're thinking about health, we need to think about what those lived experiences are of the healthcare providers who are on the ground and how we can translate that into policy, how that lived experience can inform policy and policymakers that are occurring, at the highest levels. I'll give an example. In November, I attended COP29, the United Nations Conference on Climate Change. And I was one of very few healthcare providers out of, maybe 50,000 attendees. And among those healthcare providers, as a nurse, there were maybe 5 or 6 nurses that we were able to find throughout the entire conference. Nurses, as we know, are the largest healthcare workforce in the world, but those voices are not who are providing the frontline care to conflict-affected populations, but those voices aren't represented at the larger policy levels. And I think if there's the ability to translate the lived experience of healthcare providers to policymakers and vice versa, we can better advance policy initiatives like the question we've talked about.
Thank you so much. Really good. Please, Chirian, you have the floor.
Thank you. Thank you so much. I just wanted to really highlight some of the background of the new UN Convention on the Rights of the Older Person. HelpAge International, along with network members and others, have been fighting for it for the last 15 to 16 years. The last 58th Human Rights Council session, member countries have agreed to start drafting the UN Convention. So we are in a very critical milestone. There are 3 things which I want to share in order to make and ensure that there is access to health in conflict and disaster. And the first and the foremost, we need to make sure that the older people voices, CSOs' voices are heard in drafting the new convention. It's so important. So our task would be to reach out to our 200 network members across and older people association, intergeneration groups, to really make sure that what it means in drafting a global convention and how do we seek their lived experience to shape that. That is the first and foremost we need to do. And I really call upon all those who are attending to please do make sure that we have that in the process, consultation process. This is something that we are particularly asking for. The second, the first and foremost, someone has already said, we already have many conventions. I would really like to reflect on the convention on the people with disability, which I worked on many years back. We have a lot of lessons to be learned from that. And Dr. Michael already cited, there are some gaps, even though there is a convention, but still there are gaps. So what can we learn from those conventions? What are the existing gaps? How do you ensure that that has been plugged in the new convention that we are drafting? Similarly, humanitarian law. And there are experience of implementing humanitarian law in the conflict context and situation. So how do we really look at that? And what can we learn from that? We need to have a lessons learned, really drawing the lessons from the implementation of certain instruments to really make sure that we draft a very robust convention. The third and the last and most important is that we need to understand that when you have a convention, we need to have a comprehensive look. It's not just about health, yeah? It's a whole, the health is contextual and social determinants, an ecosystem. So we need to really work on to ensure that the convention also challenge ageism, challenge abuse, age discrimination to the core of that convention, and really making sure that we overcome the isolation, the challenges that the older people are facing at the moment. At the same time, really making really sure that the really work around the health is also leading to larger well-being of the older people. That's how I need to look at it. And similarly, I just want to really emphasize the fact that the men and women are disproportionately impacted. We need to consider that. We need to acknowledge that. Where is the gender equity when it comes to the health equity? We need to consider that as well. And also the older person overlaying with disability, because we consider that 30 to 40% of older people already have one or other form of disability. How do you look at that? Lastly, which I want to say that, as Michael and others have said, the world has changed quite a lot since many convention has been drafted. The climate change, the growing refugee crisis, the displacement, and the ongoing conflict. Someone talked about, we did a research, 13 years people are displaced in Syria, and we had interviews of those stories. They must have started as in 50s, now they are ended up in 65. So what is their journey? What's their identity? So things are changing dramatically. So we need to really make sure that we address all those realities as we draft a robust convention for the rights and dignity of older people.
Thank you so much, Chirian. I totally agree. An international convention should reflect the needs and strengths of older persons, as well as feasible actions based on the information gathered from different actors working on the ground. Thank you so much. Before closing this event by using the same channels for the previous events, we warmly invite you to the third event of our series, The Right to Science and Access to Technologies for Older Persons. It will be held on Thursday, 11 September 2025, at the same time of today's event. If you registered once in one of our events of the series, there is no need to register again. You will be receiving kind reminders from UNITAR, same as we did for the previous series. We will be sharing and publishing the video recording and the takeaways document from this event at our online portfolio. Those who joined us today for at least 75% of the time to be measured by the system will be receiving information to access to your certificates of participation by UNITAR. Thank you once again, dear speakers, dear participants, for joining, and we wish you all the best in your endeavors. Thank you.
Thank you. Bye.
Thank you.
Thank you very much.
Thank you. Bye.
Great. Good. All good, girls. We can start.